Good evening. I'm Kelly Gear-Ripken, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, thank you for joining this evening for our monthly webcast series, Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. February is Heart Awareness Month. We know that gender plays a part in why heart disease remains the #1 killer of women in the US. But did you know that gender may play a role in heart surgery? Tonight, we are joined by Jennifer S. Lawton, MD, who is the Richard Bennett Darnall Professor of Surgery and Chief of the Johns Hopkins Division of Cardiac Surgery, as well as Director of the Cardiac Surgery Research Laboratory. She also is one of only 4 women heading cardiac surgery at an academic medical center, and one of only 3 women in the US whose research is supported by the National Institutes of Health, or NIH. So please use your Q&A on your screen to pose your questions to Dr. Lawton, who will respond during the last 20 minutes of tonight's conversation. The webcast will conclude at 8 p.m. this evening. I'd also like to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance. You can visit their website for additional lectures and courses throughout the year. And now I'm pleased to welcome Dr. Lawton.
Thank you so much, Kelly, for that kind introduction. As you said, I am a heart surgeon. I'm an adult cardiac heart surgeon, and I'm delighted and honored to speak to you tonight about gender differences in heart surgery. This is a brief outline of what I'd like to talk with you about tonight. I'm going to talk a little bit about the impact of cardiovascular disease, how women are different from men. I'm going to talk about the particular operation, coronary artery bypass grafting, which we often abbreviate as CABG, and some of the challenges and opportunities we have for treating women with this disease. If we look at these graphs, we can see that ischemic heart disease and stroke are the leading cause of death in the world globally. On the left, we can see the number of deaths in millions by year on the bottom from 1990 to 2019. And you can see that the number of deaths due to cardiovascular disease, unfortunately, have been rising every year. And on the right, we can see countries with the highest number of cardiovascular disease deaths. At the top, we see China, then India, then the Russian Federation, and then the United States of America. And we can see in 2019, in the dark blue, more deaths than 2010 in the light blue. We also know that the risk factor prevalence of this disease continues to rise. This is a pie chart of cardiovascular disease. It includes all of these things that you can see here. We're going to focus on the biggest portion of the pie in red, which is ischemic coronary heart disease, or blockages in the blood vessels that supply the heart with blood. I will focus on the surgery that we perform for this disease. So how does this disease work? Well, it's a plaque buildup inside the arteries that supply the heart with blood. We can see a decrease in the amount of blood flow that goes to the heart from the blood vessel on the far left, which is normal or open, followed by minimal disease in the wall, which narrows the wall and decreases the blood flow to the heart, to moderate disease and severe disease. When patients have severe disease, that is often when they are referred for coronary artery bypass surgery. This is seen here in the 4 pictures at the top, which are cross sections of those blood vessels in actual patients. This large picture is a picture of the heart. The large pumping chamber is the left ventricle, and you can see on the bottom here what a full thickness heart attack would look like, where all of this muscle is now dead, and you can imagine how this wall doesn't move anymore. And this chamber is the right ventricle. On the far left, we can see what a heart attack looks like, where we have a ruptured plaque and clot formation in the blood vessel. You can see how this will decrease the amount of blood flow to the heart. This is a chronic, almost near occlusion and a very tiny opening of the blood vessel. The next picture is a complete occlusion, and on the far right is a complete occlusion with a stent. These are the types of patients that I often see for heart surgery. Cardiovascular disease is the #1 killer of women. No, it's not breast cancer, as this Time magazine article states. In fact, more women die of heart disease than all cancers combined. This is a picture from a New York Times article entitled A Woman's Heart Attack, which is very different from a heart attack in men, and I'll tell you a little bit about that. And on the right, a Bayer aspirin advertisement. Each year, 500,000 women die from a disease that they don't even see as a serious threat. Here we can see cardiovascular disease deaths trends in the United States for men and women in red and men in blue. And you can see from 1980 to 2020, the deaths listed here. What's interesting is from 1983 until 2013, more women died in this country of cardiovascular disease than men. And many people still believe that this is a disease only in men. A lot of this decline is attributed to advertisements and education by the American Heart Association for the Go Red campaign. And this here is a picture of the Circulation Journal. This was the first journal in 2004 that was entirely devoted to assessing the risk of cardiovascular disease in women. Here we can see deaths due to cancer in red and deaths due to cardiovascular disease in blue for different age ranges. But if you just focus on the far right, you can see deaths due to cardiovascular disease in blue highly exceeds deaths due to all cancer combined in red. And this is not just a disease of older women. More than 9,000 women in this country younger than the age of 45 have a heart attack each year. I can tell you the youngest woman I've operated on for this disease was 32. The incidence is about 1 in 8 for women in the age range between 35 and 54, or excuse me, 45 and 64. And the death rate in this age range is increasing, largely due, it is believed, to the obesity epidemic, where 2 out of 3 women in this country are overweight or obese. This is an advertisement by the American Heart Association to look at this video of a young woman on the floor in her kitchen trying to prepare a meal, and she's having a heart attack. You can see she's very sweaty and she looks very scared. So let's talk a little bit about what happens to a woman who has a heart attack or presents to the hospital with this disease. Women are more likely than men to have atypical symptoms. It is more common for women to have abdominal pain, shortness of breath, nausea or dizziness, or even unexplained fatigue that increases over time. And interestingly, women have a longer time from the time when they have the symptoms begin until they come to the hospital. Do they ignore their symptoms? Do they attribute them to something different? They tend to be caregivers for other people, and they may make their own health their last priority. We know that when women have cardiovascular disease, they're different from men. They tend to be 10 years older when they come to presentation. They tend to have multiple risk factors or comorbidities, such as high blood pressure, high cholesterol, tobacco abuse, and diabetes. They tend to come with a more urgent or emergent presentation, or sudden death, where their heart stops, or silent, where they didn't even know they had a heart attack. This may be due to delay in presentation, as I mentioned earlier. And they're more likely to die within 1 year of a heart attack when compared to men. Diabetes is a much more powerful risk factor in women. They tend to have greater disabling symptoms. And interestingly, they are less likely to undergo testing, even such as a basic test like an EKG. They're less likely to receive medications that we know can improve patient health, including antiplatelet agents such as aspirin, statin medications. They're also less likely to be referred for cardiac catheterization and to receive revascularization, whether that be placement of a stent or bypass surgery. We can see from this chart on the left-hand side are what we know are the traditional risk factors for cardiovascular disease in men and women: diabetes, tobacco abuse, obesity or overweight or sedentary lifestyle, high blood pressure, and high cholesterol. We also know that age and family history are traditional risk factors, but those are not modifiable, if you will. On the right, however, are unique risk factors just for women: preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, autoimmune disease, breast cancer treatment, and depression. These are unique risk factors to women. And when a woman has preterm delivery or one of these other difficult problems during pregnancy, she is at risk for the rest of her life. The marketing project manager for physician and consumer engagement at Johns Hopkins Medicine, when I showed her this slide, her name is Yasmin Sursak-Kuhori, she stated, "This risk stays with you for life?" And then she mentioned, "It's like the tattoo that you can never get rid of." So once the changes happen in the placenta, this risk stays with you for life. And this is one of the key reasons why education of physicians is so important. Because many OB/GYN physicians, cardiologists, and primary care physicians didn't even know that more women than men died between 1984 and 2012. In addition, they're more likely to classify women as a lower risk for this disease than men, despite the same risk factors. So you can see, if a young woman has preterm delivery or gestational diabetes, it's imperative that her OB/GYN tell her at that point in time, you are at increased risk for cardiovascular disease later in life. I was delighted in 2003 when this was the Time magazine cover, Women and Heart Disease. Is your biggest worry breast cancer? Think again. 1 out of 3 women will die of heart disease. What you can do to protect yourself. I was delighted that heart disease was getting some good press. So I picked up this magazine and put it in my grocery cart, but on the back of the magazine, I was disturbed to see this advertisement for tobacco and how it glamorizes tobacco use, particularly in young women. So I didn't find that to be particularly helpful. So what about coronary artery bypass grafting surgery? This is the surgery to treat this disease. About 500,000 of these procedures are done in this country each year, and about a third are performed on women. What we do is we take a roadmap, if you will, which is this picture on the right. It's a cardiac catheterization where dye is injected in the blood vessels of the heart. This helps us identify the blockages. We then know anatomically when we operate on the patient that we need to sew this new blood vessel to bring new blood flow around the blockage, kind of like a new pipe around a block pipe. And this is an example of a piece of vein that is taken from the leg, sewn onto a blood vessel. In USA Today, there was an article in 2020 that said women face triple the danger from bypass surgery. This is very alarming, and it was based on this Circulation publication by Vaccarino and colleagues. And what they found when they looked at women less than 50 years of age, they were 3 times more likely to die with this type of surgery compared to men. And as you can see on this slide, as women aged, once they became over 70 or 80 years of age, the risk was actually the same as men. So how can this be? I've spent years trying to determine why this is the case, why the death rate is higher in women following this surgery. Many studies, just from looking retrospectively at large populations of men and women, in fact confirm that the death rate is twice that of men. However, if you look at studies that compare men and women after adjusting for risk factors, what's called propensity score matching, where women are matched with men to have the same comorbidities or risk factors, if you will, then those studies are somewhat different in their findings. This is a very contemporary publication in the Journal of American Heart Association from 2018. They looked at death rates from 1999 to 2014 in a very large population of patients. On the far left, you can see death in the hospital after surgery. In the middle, death after 30 days from surgery. And on the right, death at 1 year. And in each of the 3 graphs, deaths in women are in red, much higher than those in men in orange, over the course of the entire study. So this did in fact confirm, and many other studies have confirmed, higher death rates in women after bypass surgery. This is another study of a large population of patients, more than 2 million patients in the United States, of which about a third are women. And you can see on the right here, women were more likely to have chest complications, stroke, and death following bypass surgery. What about propensity score matching? That's where we match each woman with each man to try to make them look the same before we compare their outcomes. Well, if you look at this study from 2003 to 2016, deaths in women in red and deaths in men in blue, again, women had more deaths in 3.8 million patients when they had heart surgery after a myocardial infarction. And this difference persisted over the course of this entire study. What about ages of women? Is it different if women are older or younger if we compare death rates? Well, in this contemporary study published just last year of more than 17,000 patients, and again, they matched the men with the women, and they found that women who were younger, less than 70 years of age, the survival rate was much less than that in men. So that the younger women may actually be contributing more to this death rate. So this is consistent with the original paper I showed you at the very beginning, where women had a death rate of 3 times that of men after bypass surgery. So are these differences in outcomes due to our operative technique as surgeons? Is it something that we're doing that we shouldn't be doing or that we should change? Is it the anatomy that's different between men and women? Is it surgeon bias? These two figures are things that we think of before surgery on the left to determine risk, if a patient can get through the operation safely, and on the right, what we do in the operating room to plan the surgery. So the choice of a conduit, there are different choices for using conduit, which is the new bypass graft, if you will. You can use vein from the leg, or you can use an artery from the arm or the chest wall. Use of the cardiopulmonary bypass machine could be chosen as one of the options. And we know that women are less likely to receive complete revascularization, which I'll tell you a little bit about, and they're more likely to have smaller coronary arteries. So let's look at each of these. This slide is from the American Heart Association, and these are the brand new guidelines for coronary revascularization that just came out. When the American Heart Association has a class 1 recommendation, it means that is something that should be done. In other words, the benefit of doing it greatly outweighs the risk. We can see on the far left here, the use of the artery in the arm, the radial artery, as one of the bypass grafts, if you will, is a class 1 recommendation. It should be used in preference to a piece of vein from the leg because it stays open longer, it is less likely to have the same disease, and therefore prolongs survival of the patient. In the middle, the use of the artery from inside the chest wall, called the internal mammary artery, or IMA, again, a class 1 recommendation. Benefit greatly outweighs the risk. We know that this blood vessel used to the artery on the front of the heart here prolongs survival in our patients. It's wonderful to be able to tell a patient who's coming to surgery, I can actually hopefully give you more years of life. What more would you want from the operation than prolonged survival? And on the right, BIMA, in other words, bilateral internal mammary artery grafts, using the artery from the right side of the chest and the left side of the chest. Again, using 2 arteries is better than 1. And this is a class 2A recommendation. In other words, the benefit still outweighs the risk. So these are the guidelines. So if we look at large groups of women, we know that women are less likely than men to receive these arterial grafts despite the guidelines, despite the fact that we know that they prolong survival and can reduce death due to myocardial infarction. And women are less likely to receive all 3 of these arterial grafts. This is a very large study of almost 3 million patients in this country. And you can see the use of the left internal mammary artery here in the dotted line in black, much higher than that in women in the red dotted line. In the straight lines here, the use of the bilateral or both internal mammary arteries in men in black and in women in red. And the dotted line, use of the radial artery. Each of these 3 is highly significant. In other words, women were less likely to receive these grafts. What about complete revascularization? So bringing new blood flow to all areas of the heart muscle that need more blood flow. Well, it turns out women are less likely to receive complete revascularization. In other words, they receive fewer grafts. This is something that also comes out of that very large study of almost 3 million patients. Women were less likely to receive grafts to every territory needed during surgery than men, and this was highly significant. What about the use of the heart-lung machine? Well, interestingly, when you don't use the heart-lung machine and perform the operation off pump or without the pump, actually women have the same mortality as men. And this may be related to the fact that women are much higher risk than men for surgery. Is it because women have smaller coronary arteries? Probably not. If it is much more technically challenging to sew a smaller blood vessel, then why would women fare better without the heart-lung machine when the heart is still moving and it's more technically challenging? In addition, we know that the disparity in death rate actually decreases as women age, as I mentioned before. And we know that the time to sew this new blood vessel is the same for women and men. So it's probably not all due to coronary artery size. This is another one of the new guidelines from the American Heart Association. We know that health disparities by sex and race are evident across the spectrum of cardiovascular disease in the United States. We know that women and non-white patients are less likely to receive these guideline-directed therapies that we just mentioned. In addition, we know that they will benefit from these therapies. So this class 1 recommendation, in other words, benefit greatly outweighs risk in patients who require coronary revascularization, be that bypass surgery or stent. Treatment decisions should be based on clinical indication, regardless of sex, race, or ethnicity, and efforts to reduce disparities in care are warranted. Very strong recommendation. So what are the contributors that lead to high death rate in women compared to men? Well, as we said, higher comorbidities. Women tend to be sicker and they present later in the disease. They tend to present acutely with an unstable presentation. They tend to have delayed diagnosis and treatment, and this may be due to bias, although it's hard to tell. Not only do physicians not perceive this to be as a great risk for patients, but also patients also have a reduced sense of what their primary health risk. If you look at large surveys of women, they don't list cardiovascular disease as their main health risk. We know that women are less likely to receive guideline-directed surgical treatment, as I mentioned. And another thing is that women are not involved in clinical trials. Women traditionally have not been involved in basic science research, where we look at the actual pathophysiology of this disease. The National Institutes of Health now has a rigor and reproducibility requirement. And so if you're not going to use both male and female subjects, whether they be animal subjects or clinical trials patients, you have to actually justify why you're not including women. So how can we optimize outcomes? Well, improved education of patients and physicians regarding not only risk, but also diagnosis. We can urge people to follow the guidelines as we listed from the American Heart Association. We can urge to include more women in clinical trials, and there are many barriers to this that we could discuss. And consider specialization in coronary surgery. Coronary surgery is one of the operations that all cardiac surgeons tend to do. So if we specialize in coronary surgery, just as many surgeons specialize in aortic surgery or transplantation surgery, if we had coronary specialists, perhaps women would receive better care. We know that female patients with cardiovascular disease are more likely to receive guideline recommended care when treated by a female physician. And they have improved outcomes when patient and physician have concordance. In other words, they look the same or they are the same. These are two pictures from my operating room on days when my entire team was made up of women. That includes perfusionists, my fellow, my resident, the anesthesiologist, the physician assistant, and all of the nurses. So the future, concordance, the ultimate in specialization. We tailor the strategies specifically for women for optimal outcomes. And perhaps there could be centers of excellence. These are some pictures of the specialists in cardiovascular disease at Johns Hopkins, cardiologists, cardiac surgeon, and vascular surgeons. This is a picture of the Women's Cardiovascular Health Center at Johns Hopkins, where we provide specialized care for heart disease in women. I urge you to not only take a look at this website, but also the American Heart Association website, which has a lot of information about heart disease in women. It has been my privilege to discuss this topic with you, and I look forward to your questions. Thank you.
Thank you, Dr. Lawton. Really wonderful and surprising information, I would say. I think most people don't realize, number one, that heart disease is the number one killer for deaths among women. So, and that their care is quite different when you have a heart attack, and it presents itself differently. So let's just jump right into the questions. How about that? And so first of all, it sounds like Johns Hopkins is uniquely qualified to address these special needs. Would you agree with that? Because of why would you think that just Johns Hopkins? It's because they now have clued into this about women?
Absolutely. So there's a great deal of research being done, not only basic science research, but also clinical research to look at disparities with this disease. And also, based on the pictures I just showed you, right, it is very uncommon to have all of those women taking care of women in one institution. And just looking at my own specialty, women in my specialty are about 3 to 5% of the entire group. So we are very lucky to have women in all of those areas that can specialize in the care of women.
Mm-hmm. So would you say now that's becoming the norm when women come in for heart surgery at Johns Hopkins, that they're using a all women's team, or it hasn't quite gotten there yet? It's on its way.
Right. No, it hasn't quite gotten there yet. I consider myself a coronary specialist, but all of my partners do coronary surgery, and they do it very well. And I think it will be a long time before it would be an all-female team.
Sure. Yep. I can imagine. All right. Well, let's jump right in. This is a question from Lisa, and she would like to know, when you started off your discussion this evening, so how do you know the typical symptoms that you showed on your graph? So what should you do if you have those? Because like you mentioned, most women get at least a couple of those, quite often, if not all of them. And so what do you do? Or what should you
do? The best thing would be to go to your primary doctor and ask that person to help you calculate your 10-year risk of this disease, talk about your risk factors, talk about your symptoms, and then determine where to go from there in terms of testing. Is it indicated? Should you have an EKG? Should you have a stress test or an echocardiogram? And if you're not happy with the level of interest, then find a physician that is. There are many that are very interested in helping you determine if these symptoms are in fact due to heart disease.
So how would you know then, if you're having these symptoms, how do you know not to call 911 as opposed to your physician? It's happening at nighttime and you're not quite sure. So what would you do? What would you suggest?
And sometimes you don't know. And I would say it's better to be safe than sorry. When I'm seeing patients in consultation before actually operating on them, I always say, if you have a nitroglycerin tablet, take that, take an aspirin, call 911. The thing about calling 911 is you're going to be in the hands of someone that not only can give you therapy, but also will have what's called a defibrillator. So if you have an abnormal heart rhythm, they can get you out of it. If you're in the car with your family member, they're not going to be able to give you treatment and appropriately care for you if you are having a heart attack.
Great. Thank you. So Pam would like to know, so what can we do as women to advocate for our specific gender needs when we are contemplating heart surgery?
The best thing to do would be to ask questions. Come prepared. You can read about the surgery, you can learn about the surgery. Come prepared with questions as, what would be your plan for the bypass conduit? Are you going to use the heart-lung machine? And I have people asking me almost every day, how many of these have you done? And that's a good question to ask, because you want someone who's experienced, who tends to use more arterial grafts, We also have something at Johns Hopkins called ERAS, Early Recovery After Surgery, where we try to limit narcotics during the operation. We try to wake you up as fast as possible. We try to get the breathing tube out in the operating room and move you along, getting you home, hopefully sooner.
Great, thank you. This next question is from Ellen, and she would like to know, you've mentioned this, why do more women die from heart surgery than men, which you've mentioned during your presentation, but maybe just briefly touch on that. Again, just kind of in a snapshot answer.
It's probably multifactorial, and it could be due to any of the things I mentioned. Technically challenging, they tend to present sicker, and we don't know so much about the disease because much of the research we have is done in men, and so we may be missing something that we don't even know about in women.
So would you say then when a woman comes to the ER and they don't have the same symptoms as a man having a heart attack, do you think that they are being respected and listened to in the ER? Or do you think they're looking at something else because they're just not thinking these are not normal symptoms, quote, normal symptoms?
That is a very good question. There are many diseases that we treat that just don't seem to be on the top of the differential diagnosis, if you will, for many physicians. And we live and breathe it every day. So we think, wow, why didn't they think of a heart attack or an aortic dissection or something? But it's good to advocate for yourself. You know, if you're worried about it, you can always say, do you think this could be my heart? Or, you know, advocate for yourself, and hopefully with more education, people will realize that it is the #1 killer of women.
Right. Great. Thank you. Our next question is from Rona, and she would like to know, so are all procedures offered to women as they would be to men, or are just certain procedures offered to women?
We would like to think that all procedures were offered to all patients. But for some reason, as you saw with some of my slides, women tend not to be referred as often as men. Perhaps there are good reasons in each of those cases. Perhaps there's some bias, but you know, we strive to offer the best care to every patient. As you saw in that American Heart Association guideline, we need to treat everyone the same, with the same amount of you know, intense interest in getting to the bottom of what the problem is.
So if you are in the ER, would the average cardiac doctor coming into the ER then know that women need to be treated, you know, need to be treated differently, or they have different symptoms, and what should they do? Or is that really not the rule of thumb?
It's hard to make generalized statements about physicians in the emergency room, but I would say most cardiac specialists realize that it's a disease of all patients, and it's the #1 killer of everyone in this country. So it should always be up at the top of consideration for what's going on with the patient.
Well, here's a question from Denise, and she wants to know, so is the treatment of not taking women seriously and withholding certain surgical options to women, etc., are the results, are they, you know, basic gender differences between, you know, female and males? Are they, I guess her question is, are they being biased?
That's a good question. And many people have suggested that there is some bias against women, or it may be that really isn't an intentional bias, but a lack of knowledge about the disease in women. And there are many tests that we do to diagnose this disease that are not as effective or specific in women, make it more difficult to determine if a stress test is positive, or some echocardiograms may not be as helpful due to breast tissue compared with men. So many of the steps along the way can be complex. And So it's hard to say that it's all bias, but many people have suggested that there is bias.
Mm-hmm. Yep, I would imagine. But well, we're learning about it now, right? So hopefully things will change quickly. So our next question is from Mary Ellen, and she would like to know, is there a difference between men and women in terms of types of blockage, like differences in lateral, anterior, descending artery?
That is a great question, and I didn't have a lot of time to focus on that, but women are actually more likely than men to have what we call non-obstructive coronary disease. So disease in the small blood vessels that may not be seen on the angiography pictures that I showed. And those patients still have bad outcomes and they still have chest pain. So it's often hard to diagnose that, as you could imagine, because it's not seen on those pictures. And so in those patients, it can be very hard to find the right test to diagnose that non-obstructive blockage. But when I operate on the blood vessels of men and women, they're pretty much the same. That, you know, the disease is severe. There's calcium in the blood vessels. It's difficult to sew to them sometimes, but they're not that different anatomically. If you told me this was a man or a woman looking at a heart, I wouldn't likely know the difference other than perhaps size.
Mm-hmm. Great, thank you, Dr. Lawton. Our next question is from Donna, and she'd like to know, so if one is being treated for breast cancer and needs to take supplemental calcium and the inhibitors and any other drugs that may be required, can any of these medications increase your risk of cardiac disease?
Yes, and you may have noticed on that slide of risk factors, breast cancer treatment was on there as a risk factor. And that's because some of these medications can cause damage to the heart, and also the radiation to the chest can cause blockages in the blood vessels of the heart, and also damage to the heart valves. But in those situations, it's best to weigh the risks and the benefits of the treatment at the time with your physician, because that may be the more important treatment at the time, you know, to try to fight the cancer, rather than avoiding something because it could increase your risk of cardiovascular disease.
Of course. And then perhaps to follow up then with your internist or physician, just to double check on those things.
Absolutely. Keeping that in mind the whole time. And obviously the diagnosis of breast cancer is a devastating and very frightening diagnosis. And you need to sort of focus your attention on fighting that problem at that time. And then, but keep it in the back of your mind that once you get through that therapy or whatever treatment you're having, come back to that. You know, the cardiovascular disease, could I be at increased risk now? What should we do to calculate my risk or determine if I need to make some changes?
Sure. Well, and then on that note, with as far as following up on from taking those types of medicines or having those types of treatments, but in general, a person who is not undergoing those, but they have you know, heart disease in their family, a young woman has heart disease in her family, when is a good time to start sort of having your baseline taken? You know, is there one? You know, you go in for your physical, but you know, at 30 years of age or 35 years of age, you may not be doing all of these things. So what would you recommend as you know, good practice for that, you know, being proactive?
Well, you know, there are many occupations where men have classically gotten a stress test at the age of 50, or maybe a yearly stress test, such as pilots or other certain types of occupations. And so probably around the same time, that's when you're supposed to get your first colonoscopy. But if you know that you have a strong family history and you have a lot of these risk factors, you may want to ask your primary care doctor before that age to say, hey, I'm a little bit worried about this. And then the most important thing to do at that time is to, what the American Heart Association says, know your numbers. So ask, is my cholesterol high? Should I be how can I lower my cholesterol? I can change my diet, but if it runs in your family, you may have to take medication. What is my blood pressure? Do I have a high blood sugar or diabetes? What is my weight and my height and my body mass index? Am I overweight or obese? A lot of times when I talk about this disease in a auditorium or where women are seated, I'll say either you or the woman to your right or to the left, two of you are overweight or obese in this country. So
Wow.
it really sort of brings it home that, what is my body mass index? And maybe I should be concerned about exercising more or, knowing all of those numbers.
I think that's a great point, because I think a lot of women who exercise in particular think, okay, I'm exercising and I'm watching my diet, and so I it seemed to be pretty good, so my body mass and index must be down and everything must be okay. But the fact of the matter is you really don't know, right, until you get these things checked.
Exactly. And I exercise every day, and I can't, I am unable to bring my cholesterol to a normal level because it runs in my family and I have familial elevation. So I take medication. And don't be afraid to take a medication that will help you reduce your risk of this disease, because it's important.
That's another great point of people who think, because of exercising, but if they still have high blood pressure, they may need to take medication to lower that, not just exercise and watching what you eat. So good point. Our next question, Dr. Lawton, is from Denise, and she wants to know, why is diabetes such a great risk for cardiac event?
We call it an evil disease because the elevation in the blood sugar in the bloodstream has very detrimental effects on the blood vessels. And we even say sometimes when we look at those angiograms, these are diabetic blood vessels because they tend to be smaller, heavily calcified. It wreaks havoc, if you will, and much more devastating in women than men, and why we don't really know. So much more research needs to be done on that.
I'm going to say hormones. I blame everything on hormone. I get to say that because I'm not a physician, so that's just my 2 cents. Anyway, with that too, but if you have, Marcia wants to know, if you have diabetes, your diabetes under control, does it make a difference in what you just said?
Absolutely. It should help. It should help reduce your risk, but it's still a risk factor for this disease. And you mentioned hormones. I didn't talk about that at all either, but there are very large randomized trials in women that documented that hormone replacement therapy to reduce risk of this disease is actually a class of recommendation 3, which means harm. It does not reduce risk of this disease. Many people believe that taking hormones, estrogen or progesterone, is protective in younger women and that you should take it postmenopausal, but it is actually not beneficial.
Interesting. I didn't know that. That's another great point about hormones. There they are.
And in fact, after surgery in my female patients, I try to convince them to stop taking hormone replacement therapy if I can coerce them the risk and benefit of hot flushes and the disease.
Is it just because, why is that? What do you know why taking the hormones is harmful? What do you actually know why? The scientific reason why?
Well, the women in those trials had other side effects related to it, whether they be formation of clot or other types of diseases. And it did not prevent, there were no decreased cardiovascular events in those women at all. So because of that, there was harm associated with taking it.
I see. Thank you. Thank you for clarifying. This next question is from Diana, and she would like to know, how much does an elevated coronary calcium score contribute to plaque buildup? And then when you answer that one, I've got follow-up.
Okay, so the score doesn't actually contribute to, the score is sort of an assessment of the amount of calcium in the blood vessels and it is often correlated with the degree of blockages, but not, it is not what we would call the gold standard to diagnose the disease. It's often a first step to see if you have a high amount of calcium or a lot of calcium burden in the blood vessels. And then the gold standard still remains the angiogram, like the picture I showed you where we inject the dye into the blood vessel. And that actually shows you if the calcium is actually associated with a significant narrowing in the blood vessel.
I see. So her next part of that question, Diana's question, so taking daily doses like 1,200 milligrams of calcium supplements, does it increase the risk for cardiac calcification in women over 35?
No, it shouldn't. If you're taking the calcium for another reason that's important, that your physician recommends, it should not. We know that lowering calcium in the bloodstream can have an effect on sometimes on calcification of heart valves, but it shouldn't increase your risk for cardiovascular disease.
Okay, thank you. Our next question is from Holly, and she would like to know, so can you describe what TAVR is? TAVAR.
Absolutely. So that's transcatheter aortic valve replacement. So what that means is we can take the blood vessel in the leg, or sometimes the blood vessel in the neck, and put a catheter in and replace a valve by putting a wire through your valve and blowing up a balloon and then deploying a valve with a stent inside of it without opening the chest. So it's all done via catheter.
Great. So have these been tested on women or just men?
Yes. Interestingly, if you look at the traditional surgical aortic valve replacement, where we open the chest or open a part of the chest, women tend to not do as well as men in that, what's called surgical AVR or SAVR. But in TAVR, through the groin vessel, actually women do, we believe, in the data that we have so far, just as well as men.
Great. Good news. Good to hear. So Dr. The next question here is, let's see, is from Denise, another Denise. She would like to know, what's the latest guidelines for aspirin? And are they different for women?
So the new American Heart Association guidelines address aspirin after either stent or coronary bypass surgery, and they're the same recommendations for men: aspirin to reduce risk of cardiovascular disease and also to keep those vein grafts open. So if we do use a piece of vein for one of those bypass, we do recommend aspirin for that, and also aspirin for patients who have had stents. They typically take aspirin and another medicine to inhibit platelet activity. And those are the same recommendations for men and women.
Okay, great. Thank you very much. Let's see, Dr. Lawton, the next question is from Alicia. And she'd like to know, are women more prone to inflammation in scoring post-op? And does that make them more prone to stiff atrium syndrome later?
I am not aware of any studies that say that women are more prone to inflammation post-operatively. Inflammation post-operatively is often associated with an abnormal heart rhythm, but I'm not aware of studies looking at something called stiff atrial, maybe atrial fibrillation is what the question was, or?
It says more prone to, it says stiff atrium syndrome.
Okay.
Possibly typed in wrong, but that's what it says. Yeah.
Yeah, not that I'm aware of.
Great, thank you. Our next question is from Robin, and she wants to know how many weeks is considered preterm delivery in relation to heart risks later in life. And this preterm labor that was stopped also considered to be risk for future heart disease?
The preterm labor, I honestly don't remember the number of weeks it is, but if you look at that, I can go back to that slide and show you the, are you still seeing the slides?
I will see something different than they do.
Okay, let's see
Yep.
if I can go back, show you that. I should know that if I were an OBGYN, I would know that, but I have not retained that number in my brain.
I think you've got enough on your plate there.
So this is the study by Garcia.
There, they can see that. Yep.
Yeah. If you look at that study, it'll tell you the exact number of weeks, and I don't remember if it was 30 or earlier. I think that there's a gradation of risk, but I honestly don't recall the exact numbers.
Mm-hmm. Okay, thank you. Our next question is from Cindy, and she would like to know, can women fully recover and resume their lifestyle following cardiac surgery, or are there particular risks since women are typically 10 years older than men when cardiac health begins to deteriorate?
Absolutely, they can go back to life. Absolutely. I mean, that's the whole reason to do the operation, is to get you feeling better than you are now or before, to take away the fatigue, the chest pain, the shortness of breath, and to give you longer life that's better quality of life. If that were not the case, then we would not be doing this surgery. And, and depending on how active you are before surgery, if you exercise regularly, if you're very active, you'll do better with recovery. You may need to go to what's called cardiac rehab afterwards to help you get your strength back if you're not as active. But absolutely, by 4 weeks, when the breastbone is healed, I expect you to go back to doing everything you did before and more.
I love that. It is great incentive to do that. And on that note, is the recovery from heart surgery different for women than men?
There are some studies when we look back at large numbers of patients that women tend to need more help after they go home. It may be just because they're typically caregivers and it's hard for them to find caregivers, and they may not do as well with cardiac rehab, but it's hard to make general conclusions regarding that. Interestingly, back in the 1980s, there was an American Heart Association session entitled, "How can I help my husband recover from heart surgery?" And that was when we didn't think it was a disease in women.
Nice. So they don't have that for women?
Yeah, exactly. We need to have that now.
Yes, no. Yes, they need to get on that. Our next question is from Claire. She'd like to know, how frequently do you need to have calcium score tests, and does it predict your risk of having a coronary blockage?
It can correlate with significant blockages, but again, the gold standard test is really going to be the angiography, and the frequency with which you should have one of those should be something you discuss with your primary care doctor, because each time you have a CAT scan, you get a tiny bit of radiation, and if you don't have change in symptoms, you don't have change in risk factors, you may not want to do that frequently, and it would depend on an assessment of your risk, and is this test really going to change what we're doing for your treatment right now or not?
Right. Excellent advice. Thank you. You know, you haven't, I don't believe you've mentioned about pacemakers and pacemakers in women. Are they used often and or not? And does it help the same way that it helps a man, or what's your thoughts on in your research on pacemakers?
I would say they're just as beneficial as they are in men. I don't know a lot of data on how women do after pacemakers. They're so slick now. They're so small. They're able to do them just in the skin or subcutaneous tissue. So, you know, I believe women probably do as well as men, but I don't have any data to share with you about that.
Hmm. So it's really, if it's necessary, if your cardiologist is saying you need to have a pacemaker as a woman, you should think twice about it and get it possibly. There's no, gee, we've only done this on men.
No, no, absolutely, absolutely. And if you just need a basic one, they're pretty small now, almost
Mhm.
like a little bit bigger than a quarter or a $50, and they go right underneath the collarbone usually. And it's something you can have done under just a little numbing medicine and sleepy medicine, if
Mhm.
it's not a complex one. So if they recommend it, I would highly recommend that you go with that recommendation.
Thank you. Our next question is from Janine, and she'd like to know, what is the link between autoimmune disease and the risk of heart disease? Good question.
Yeah, great question. So these are diseases like lupus and rheumatoid arthritis, which
Mhm.
tend to be much stronger risk factors in women than men. And a lot of that, I don't know the pathophysiology about that, but they tend to affect women in a higher, more severe risk factor.
Mhm. Yeah, it's interesting because you mentioned that in your presentation, actually on this chart, this graph that's up about autoimmune diseases, and sort of the correlation there. That's very interesting. So, Dr. Lawton, our next question I have for you actually, what research is being conducted at Johns Hopkins Medicine and other medical centers? And then also a two-part, if you could explain some of your own research would be lovely.
Absolutely. So there's a large amount of research, not only in the disparities of healthcare for cardiovascular research, not only women, but other groups of patients, and lots of research on heart disease, not only in cardiology, but cardiac surgery, vascular surgery. My research, I have both basic science research and clinical research. I tend to focus on heart disease in women for clinical research. Um, and you mentioned my funding, my basic science research has been funded by the NIH. And interestingly, my focus sort of parallels my clinical interests. I try to make solutions to protect the heart during heart surgery better. So when we use the heart-lung machine, we actually stop the heart and deprive it of blood flow during the time of the operation so that we can safely operate on it. So it's kind of like a catch-22. We take a sick heart and we want to make it better, but we deprive it of blood flow while we operate on it.
Sure.
So I look at ion channels in the heart and how I can use the heart's own innate protection to make those solutions better so that the heart functions better after heart surgery.
So even though you were a bit concerned, you were talking about the heart and lung machine, that it seems to be a little bit more dangerous on women, but that is one of your focuses in your research.
Absolutely, because doing the operation without the heart-lung machine is a little bit more technically challenging. And if you don't do that frequently and a large volume of that, your outcomes may not be as good as someone who does. And so it's not for everyone.
Mm-hmm. Yeah, I can imagine. So why on operating? So why is there higher deaths in women after the bypass surgery
You mean with the heart-lung machine?
without the heart lung machine? I'm sorry.
Oh, why do they do as well as men?
No, why they don't do it. So I'm sorry, to clarify, the question is, why is there higher deaths in women after bypass surgery? Is that only when is it higher when they're only using the heart and lung machine, or not?
Oh, yes. If you look at only women who have the surgery without the heart-lung machine,
Mm-hmm.
because they tend to be higher risk because of the comorbidities, in many studies, they have the same death rate as men because many people believe that method particularly benefits high-risk patients.
Great. Well, listen, Dr. Lawton, it looks like we're running out of time. And I'd like to thank you so much and thank each of you for joining us this evening. And graciously, Dr. Lawton has agreed to respond to questions that were not addressed this evening, but we got to most of them. And you'll receive an email with her answers in approximately 2 weeks. In the coming days, the video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/A Woman's Journey, under Conversations That Matter. If you'd enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for information about future conversations and podcasts, all featuring Johns Hopkins physicians and faculty, and brought to you by A Woman's Journey. In the meantime, we hope you'll find our monthly email informative and engaging. Good night and stay well.